Дорогие коллеги, для меня большая честь быть на вашей важной конференции. И я также хотел бы поблагодарить Юлию Савочкину за мое приглашение и также снова стать с другами из Беларуси и в этом прекрасном городе Минске. Но я, к сожалению, не могу говорить по-русски, потому что я не так хорошо говорю, не надо говорить по-английскому. Да, будем продолжать по-английски. Dear friends, dear colleagues, we will switch to another topics now. We will talk about the recurrent pregnancy loss and the possibilities, how to diagnose this in these conditions and how to treat. Well, I would like to perhaps compare this situation, or habit to abortion is something which reminds me on IVF situation some 40 years ago, when there was no IVF, no possibility to effectively treat infertility, and a lot of the treatment was magic, and unfortunately there are also other conditions like premature delivery, which is still the fight against it. There are many studies, there are many trials to treat, but we are very unsuccessful, and many of the treatments, again, are very close to magic. So we have to, when we want to treat habitual abortion, which is a severe condition, we should stick to evidence-based conditions and try not just to be magicians, but to stay doctors. And this is actually the topics of my talk. Well, the recurrence problem start already with the definition. Most of the recommendation talk about two losses. Some of the recommendations expect 3 losses to call this condition recurrent pregnancy loss. We are happy with the 2 losses, and our definition, the most definitions are, we'll say, okay, let's call the condition recurrent pregnancy loss after 2 unwanted losses. It excludes ectopic pregnancy and molar pregnancy, and this thing means that the challenge is to differentiate between the sporadic miscarriage and the real recurrent loss. Most of you know this very classic pregnancy iceberg, which says that in any one cycle, the maximum probability of conception is only 30%. So this we have to keep in mind when we talk about fertility. How severe or how prevalent is recurrent pregnancy loss? Well, it's a condition which is about that we have about 1 to 2% of population suffering, of our pregnant population suffering from recurrent pregnancy loss. So it could be said that it is as common as preeclampsia in developed countries, and it is what is much more important, that this condition affects also the whole family, the whole couple, and we have to deal with it very seriously. The risk of miscarriage increases with maternal age and the number of preceding pregnancy losses, and this is an information which we unfortunately have to discuss with our patients. Paradoxically, if we know that one of the pregnancy losses was connected with unemployed pregnancy, we have at least specific diagnosis, which is, perhaps better than not to know anything about it. This is a very known graph published by Lund in 2012, showing that the number of miscarriages and the age of the women during miscarriage has an important impact on the consultation and of the chance of conceiving during the next 5 years. So if you have a woman with 3 miscarriages, the chance that she will, this is the red line, the chance that she will get pregnant in the next 5 years is about 75%. If she has 6 or more miscarriages, the chance is about half that big, so it's not more than 45%. The similar condition is if she is young, the probability that she will get a delivery baby during the next 5 years is about 80%. If she is more than 40 years, it's about 40%. Our patients, when they get pregnant, finally or again, they ask us how early or how soon can we expect that if you make the diagnosis of pregnancy that we will deliver the baby. We cannot make these judgments too early, because in the 6 weeks the probability of miscarriage is about 22%. We have to wait until the end of the first trimester where when we make the diagnosis of pregnancy, we can say about 99.4% that this pregnancy will continue to deliver. So the recurrent pregnancy loss is a multifactorial disease. Like, you know, a similar slide from the topics of premature delivery. It's also a multifactorial disease. And genetic, epigenetic, and environmental factors may contribute towards the recurrent pregnancy loss phenotype. So, because it's so multifactorial, it's not that easy to find the reasons or etiology of each single patient. I again would like to stress that recurrent pregnancy loss has a major impact on the family, and the psychosocial support in many cases is essential. So we should not forget that women suffering from 2, 3, 4 recurrent pregnancy losses very often need psychosocial support. What are the risk factors? Definitely very important is the age. You know that we are now facing some very bad time where the first pregnancy is, the average age of first pregnancy is about 30 years in Western Europe, which I do hope we will not reach. And the age is the major risk factor of pregnancy loss. Stress, we are facing stress every day in everyday life. It might contribute, but there is no evidence that stress contributes to recurrent pregnancy loss. Well, generally, we all know that the health behavior modifications might change the risk of recurrent pregnancy loss, but it's not so easy to convince our patients to lose weight, stop drinking of alcohol, and stop smoking. But it's evident that the bad lifestyle contributes to recurrent failures. Even the husband, it's a nice husband here in the picture, a typical one, might contribute to better outcomes in these conditions. So it doesn't cost anything to change lifestyle. It doesn't cost, they even can save money not eating so much, not spending money for cigarettes, and not spending money for alcohol. But, well, it might be more complicated than to send the patient to the pharmacy to buy something. Well, back to the science. Well, one of the part of the examination is the genetic investigation in recurrent pregnancy loss. Well, there are several recommendations by several important bodies, and for example, the genetic analysis of pregnancy tissue is not routinely recommended in pregnancy loss, but it may contribute to the consultation of the couple. So, because we know that about 60% of all pregnancy losses is due to unemployment, so we will usually find this situation. But on the other hand, when we know that the recurrent pregnancy loss is due to unemployment, we at least have a clue for the next consultation. So we have to just consider if to examine or not. Today we have a very strong possibility to examine the microarray, and we have to decide whether to indicate a parental karyotyping, which is also not routinely recommended in couples with recurrent pregnancy loss, but might be of interest. If you find an abnormal fetal or parental karyotype, we have to discuss with the couple all possible options, starting with sperm donation or side donation, or invasive procedure, or like amniocentesis during the next pregnancy, and there might be some translocation or some changes in the karyotype of the mother and father. There is a list of investigations in the recurrent pregnancy list. They might bring some information, like antiphospholipid antibodies, beta-2 glucoprotein, antinuclear antibodies, and of course, star-cycle screening. There are different bodies have different expectations from these examinations, but they are usually used. The other group, or the other part of the investigations is due to malformations of the uterus. You know that we have a very good possibility to make the diagnosis with transvaginal 2D or 3D ultrasound, and or together with the sonohysterography. Usually, we as gynecologists in Europe, we don't recommend MRI as a first-line option for assessment of uterine malformations. On the other hand, if there is a Müllerian uterine malformation, we should continue the diagnosis of or investigation of kidneys and urinary tract. There is a relatively new and a very good one, classification of female genital tract anomalies. You can read it on the ESHRE and ESGE pages, published in 2013, and the same is the scheme which you might know, which shows the classification of the anomalies. It is important to classify the anomalies according to the possible treatment, because each anomaly has a different recommendation to treat or not to treat. There is a long list on non-recommended investigations in the recurrent pregnancy list. Well, as I was starting my talk that we should stick to evidence-based medicine and not to be magicians, we always should think if the patient needs every specific examination and what we can expect from that examination and how we can consult the results. Because it's very simple to make a checklist of all kinds of examinations and then to have a list of results, but sometimes without knowing how to deal with these results. So I will not read all these non-recommended investigations, but I just want to stress this information. So, how to treat in recurrent pregnancy loss? So we should treat some known condition, but we should avoid to generally provide some kind of medicine which we don't know why we are providing. In the beginning, I will come back to the lifestyle. Well, we should always start with the recommendation of better lifestyle and the lifestyle changes which many of our patients will not want to hear. You know that vitamins are quite commonly used. We don't usually know why. We prescribe them. Perhaps the prophylactic vitamin D supplementation in recurrent pregnancy loss has some sense, and usually low-dose folic acid is routinely started preconceptionally to prevent neuro-tube effects. But there is not a specific advantage in using folic acid in recurrent pregnancy loss, so it will not decrease the number of recurrent pregnancy losses. You might know the Big Bang Theory series from TV, where the character Sheldon Cooper was saying that vitamins are ingredients for very expensive urine, which sometimes might be true. And if our patients ask us for vitamins, we should at least recommend those who are safe in pregnancy and avoid compositions they contain vitamin A and vitamin E, which might be dangerous. Another group of possible conditions they might cause recurrent pregnancy loss is the thrombolytic states. And when we talk about hereditary thrombophilia, it is not recommended to treat with prophylaxis unless in the context of research or if indicated for venous thromboembolism prevention. So just the information of hereditary thrombophilia is not enough to treat. But on the other hand, when we are able to diagnose antiphospholipid syndrome, it is important to treat with low-dose aspirin starting before conception and provide a prophylactic dose of low molecular heparin starting at the date of a positive pregnancy test. So this is a specific treatment for antiphospholipid syndrome. I mentioned that thyroid dysfunction is one of the diseases which might have impact on recurrent pregnancy loss. A thorough thyroid inspection or thyroid investigation is indicated in recurrent pregnancy loss, and also specific treatment to those specific conditions found during the examination is recommended. The same with hyperproteinemia. Bromocriptine treatment can increase the lifespan. There is, on the other hand, a long list of not recommended therapy, which you might not agree, but most of the big bodies are not recommending this kind of therapy, just in cases of unexplained recurrent pregnancy loss. So it means that there is not a specific diagnosis which would be treated with these therapies. It's, I can mention sperm selection, antioxidants for men, lymphocyte immunization therapy, intravenous immunoglobulin, glucocorticoid, heparin, low-dose aspirin, or vaginal progesterone in cases of unexplained recurrent pregnancy loss. It means in that cases where there might be 50%, there might be 50% of our recurrent pregnancy loss where we do not know the cause. So when we don't know the cause, we just often offer some treatment which we don't know why we are offering. This is the answer, because we don't know what to do. But we could also give hand or shake hands with the patient. It might help in the same way. The other part of the list is intralipid therapy, granulocyte monostimulating factor, and endometrial stretching, again in unexplained recurrent pregnancy loss. These recommendations are in context with the guidelines of European Society of Human Reproduction and Embryology, which have been published in November 2017. This does not really come from my head. Uterine structural disease treatment. Well, I will not go in detail, but I've shown you the classification, I've shown you the pictures. Each condition has a different approach to treat. So first is the diagnosis, and then if you have the diagnosis, we have to decide how to proceed or how to be active in surgical management. Not, it might be discussed which approach is appropriate, but sometimes we can do even more harm than doing the surgery than without doing it. You might not agree, but submucosal fibroids or endometrial polyps, there is insufficient evidence supporting hysteroscopic removal. There is insufficient evidence with removal of intramural fibroids and fibroids that might distort the uterine cavity. And again, there is insufficient evidence of benefit for surgical removal of intrauterine adhesions for pregnancy outcome, because there might be the adhesions can be there again in the short term. You know that the discussion about cervical weakness and support like cerclage, it's controversial for a long time. Well, in situations where you have several recurrent losses, it's definitely recommended to do serial cervical measurements. And the question is to provide cervical cerclage. I think it should be done in every specific case. I think it's not necessary to do it always, but there are cases where we might expect that it helps. It is, I think there cannot be done a completely general recommendation. It should be individually discussed. Well, to come to the current research, I will stress this is a research, this is not a clinical approach. So you know that there is, in the beginning I said it's a multifactorial disease. One part of causes is due to immunology changes, and this is also a part which is nicely studied, and it's possible to do a lot of research in this field. There is a recent paper about whole genome sequencing and bioinformatics analysis of women affected by recurrent pregnancy loss. They are finding mutations in matrix metalloproteinase and proteins that might have impact on functions, on stability. It is an interesting approach because you know today it's very fancy to examine the whole genome. There might be found some changes, but this will affect just a small part or a subgroup of women with recurrent pregnancy loss. In recurrent pregnancy loss and immunology, you will always hear about natural killer cells. Unfortunately, this is still a research topic. We should not start treatment regarding these findings. Natural killer cells cytotoxicity is determined by the balance of activating and inhibitory receptors. There might be some kind of natural killer cells called NK22, maybe a type of regulatory cells contributing to reproductive failure. I think for most of you who are not immunologists, this is just a really marginal topic. But what is clinically, or what might be clinically relevant, is that this condition might be, and I'm stressing this might be, treatable with intravenous immunoglobulin treatment. And in situation of high natural killer cell toxicity, it could have a positive impact regarding to these studies. So to summarize, I would like to say that we should not forget that the history is half of the diagnosis. Doesn't cost anything, just our time. But if we have a patient with recurrent pregnancy loss, we should talk with the patient and we should try to find out all information which might be necessary to know about recurrent pregnancy loss, and not just to think where to send the patient or where to send the blood or how to and whatever. First, the history might help us a lot. Then we have a list of standard evaluations like sonohysterography or ultrasound, anti-cardiolipin antibody screening, thyroid examination, and perhaps the karyotyping of the couple if necessary. The additional testing depends upon the diagnosis suggested by the history, and we have tried to be as individual as possible. We should make some conclusion regarding the possible unemployed causes, uterine abnormalities. What I would like to stress again, that supplemental vaginal progesterone is not recommended. It's quite high grade 1B recommendation in cases of unexplained recurrent pregnancy loss, because vaginal progesterone is just generally used in many cases. Use of vaginal progesterone once a pregnancy has been established does not improve live birth rate. This is, well, today seen in evidence. Immunotherapy or glucocorticoids are not recommended for treatment of recurrent pregnancy loss. These drugs are not effective and may be harmful. Treatment of hyperprolactinemia is recommended. Well, Alexander the Great said that he's dying from treatment of too many physicians. The recurrent pregnancy loss patient might say, I'm dying from too many tests and medication. Thank you very much for your attention. If Jerry wants to ask me something, he already wanted to ask me yesterday night.
Don't be so shy.
Thank you very much for that presentation. You told nothing about PGS, PGT-F1A aneuploidy. Yeah. Do you recommend it for ladies with recurrent pregnancy loss?
Well, I would say not generally. Yeah. You can consider it. Well, the problem is that, as I said in the beginning, this is a multifactorial disease. We have a patient, what we know is she has 3 recurrent pregnancy losses. Well, we make the diagnosis that this is a real recurrent pregnancy loss. And then there might be hundreds of causes. And we will be very happy if we find some specific cause. 50% will stay, or 30 to 60%, according to studies, will stay unexplained. So the patient wants us to treat, but we are in a position when it's very difficult for us to treat something we don't know what we're treating. So, and the difference between being treated and being untreated is sometimes the same. This is the problem. But of course, they expect from you that you're a magician.
Thank you very much.